Hello, this is Dr. Stephen Feldman. I'm professor of dermatology, pathology, and public health sciences at Wake Forest School of Medicine. I'll be discussing impact of withdrawal and retreatment on immunogenicity of Guselkumab in patients with moderate to severe plaque psoriasis. The poster was presented by Dr. Zhu and colleagues at the 76th annual meeting of the American Academy of Dermatology on February 16th through 20th, 2018 in San Diego, California. To summarize, previous analysis of the Voyage 1 and 2 trials demonstrated that the incidence of anti-drug antibodies to Guselkumab was 6% up to week 48, with no impact on Guselkumab exposure, treatment efficacy, or development of injection site reactions. The present analysis, which involves patients from Voyage 2, found that anti-drug antibodies were detected in 10.2% of patients who were withdrawn and retreated with Guselkumab, compared with 6.8% of patients who continued with Guselkumab throughout week 100. Systemic exposure to Guselkumab and efficacy were regained after retreatment with Guselkumab, with no observed clinically important injection site or hypersensitivity reactions. The findings of this trial provide reassurance as to the continued efficacy and safety, including the development of anti-drug antibodies of Guselkumab despite withdrawal and subsequent retreatment, which is often encountered in clinical practice. Methods. Patients with moderate to severe psoriasis were randomized 2 to 1 to 1 to one of 3 groups. Group number 1 got Guselkumab 100 milligrams at weeks 0, 4, 12, and 20. Group number 2 received placebo at weeks 0, 4, and 12, followed by Guselkumab 100 milligrams at weeks 16 and 20. And group number 3 received adalimumab 80 milligrams at week 0, 40 milligrams at week 1, then 40 milligrams every 2 weeks through week 23. At week 28, Psoriasis Area and Severity Index, PASI 90 responders in group 1 were re-randomized 1 to 1 to either continue Guselkumab every 8 weeks or withdraw from Guselkumab. Withdrawal patients were retreated with Guselkumab upon loss of greater than 50% of the PASI improvement they had achieved at week 28. PASI 90 responders in groups 2 and 3 were withdrawn from Guselkumab or adalimumab. Upon loss of greater than 50% of the PASI improvement they had achieved at week 28, Guselkumab was started or restarted. PASI 90 non-responders in all groups continued or started Guselkumab. From week 76 to week 100, all patients received open-label Guselkumab 100 milligrams every 8 weeks. Key findings of the study: of the 992 patients in Voyage 2, 947 received Guselkumab at some point in the trial and had serum samples that were evaluable for anti-drug antibodies. The overall incidence of anti-drug antibodies was 8.6%. Titers were less than or equal to 1 in 160 in 76.5% and less than or equal to 1 in 320 in 90.1%. The overall incidence of neutralizing antibodies was 0.4%. The incidence of anti-drug antibodies occurring after exposure to Guselkumab was 10.2% in those who were withdrawn and retreated with Guselkumab, compared with 6.8% of those who continued Guselkumab. There was no impact of anti-drug antibodies on systemic exposure of Guselkumab. Between patients who were positive for anti-drug antibodies and those who were negative for anti-drug antibodies, and between and after development of anti-drug antibodies within a patient. Among the 32 patients withdrawn and retreated with Guselkumab who were positive for anti-drug antibodies, the trough serum concentration of Guselkumab recovered to the level achieved prior to withdrawal. 100% achieved an IGA score, an Investigator Global Assessment score, of 0 or 1. 93.8% achieved PASI 90. 2 injections were associated with a mild injection site reaction, and there was no anaphylactic or serum sickness-like reactions to Guselkumab reported. Here are my thoughts and analysis of this study. Let's highlight the main points of the study. First, titers of antibodies to drugs doesn't mean much to me. Every company has their own assay. What numbers we get are just numbers. We can't compare across drugs. And the percent of patients who have a positive antibody response may depend totally on how much antibody was considered to be a positive result. I pretty much ignore these antibody rates. What matters to me is the efficacy and safety of the drug. And when at least 9 out of 10 patients are having a great response, Anti-drug antibody must not be that important. How do the results of this study impact the current state of patient management? This study showed that even when there was detectable antibody, it didn't seem to make any difference to the efficacy of the drug. And when patients stop and restart, the drug should still work. Now, we may not tell patients to stop and restart, but they may do it anyway. But perhaps because of a lapse of insurance, perhaps because they just wanted to see what would happen if they stopped treatment. It's reassuring to know the drug will still work. How do the results of this study impact the future state of patient management? With 2 years of great efficacy and safety data, Guselkumab is clearly among our really good psoriasis treatment. I'm looking forward to seeing us have more of these IL-23 blocker choices. What questions remain unanswered? 2 years of data is very good. I'm looking forward to when we have 5 years of efficacy and safety data. I anticipate it will be solid, but we won't know with certainty until we see it.